Let's see. Well, I have exactly noon Pacific time and 8 p.m. BST for Dr. Panicker, but welcome everyone to another program on NeuroLife Online. My name is Andrea Merriam with PMD Alliance, and we're so excited for you to be joining us from, let's see, Berkeley, California, Florida, Silver Spring, Maryland, Ocean Isle Beach, North Carolina, New Jersey, Arizona, Atlanta. Oh, we have a great variety today. Welcome everyone from across the country. Today, our expert, let's see if I see Dr. Subramanian. Yes, I will let Dr. Subramanian share a little bit more about Dr. Panicker and why we had to go beyond the old USA and reached out to Dr. Panicker to talk about this topic. Let's see, if anyone else has any other questions, send us a note in the chat as the presentation goes on. You can either hold your questions or put them in. We'll be actively monitoring those. And also at the end of the program, we will be posting the recording of this program and sharing resources that we talk about. So, well, let's jump right in. We have lots to cover, and I'll go ahead and turn it over to Dr. Subramanian to get things started.
Thank you. Hi, everyone from our virtual group plan. Hi, Jalesh. Thank you so much for joining us this evening in the UK. So as you can see, we're bringing some pretty awesome speakers to you. We had Miriam Perry. If you missed it on Friday, that video should be up talking about sexual dysfunction and identifying those issues. And I've reached far and wide across the world, and people in this socially distanced world are virtually connecting in a way that I think is pretty spectacular. So we've just been so excited to have some of our speakers join us from the UK and from Australia as well. We'll be having some speakers in the next month or so coming in from all kinds of time zones. So I really appreciate them changing around their schedules and different time zones and accommodating us. But it's my pleasure to introduce Jalesh Panicker. He is a neurologist who has had a really interesting kind of background leading up to an interest in dysfunction of bladder and even some gynecological and neurological specialties as well. He has a background in neurology and taking care of multiple sclerosis patients historically in these arenas, and now has developed an increasing interest and really has been publishing a lot and looking into this area of Parkinson's disease. And so I've been trying to entice him more into the Parkinson's world because I think there's so many unmet needs in this area, and it was my pleasure to have him join us today from England. He's at Queen Square, and he is working there with their patients in neurology, and it's a really unique experience, I think, that he's developed with this host of different types of patients and really brings this wealth of experience to this specific issue. So excited to have him. Maybe we'll learn a little bit more about you, Jalesh. Tell us a little bit about how you got interested in neurology and how you developed an interest in the bladder dysfunction area specifically.
Well, good morning, good afternoon, and good evening. And it's great to be here. It's quite a paradox, isn't it, with COVID-19 and with the physical distancing that's there, whereas actually Zoom and these sort of fora have actually brought us together. So I started out with neurology, and my interest was actually in rehabilitation from a neurological perspective. And soon enough, it became clear that actually we're very good with mobility and actually managing issues of mobility and disabilities from a physical side of things. But actually, when it comes from perspective of the bladder, there's actually very little that we were offering in a neurorehabilitation setup. And so whereas urologists understand the bladder, the neurologists understand how the bladder works. And that's where I come in between as a uro-neurologist, a neurologist with interest in the bladder, as contrast to a neuro-urologist, who's a urologist who's interested in neurological disease. And so that's how things started, and it's something that I am passionate about. With Parkinson's disease, I think it's something of an area that's a bit neglected when it comes to the bladder. And over the years at Queen Square, we've actually developed a program for addressing and managing the bladder and Parkinson's. What I've done is actually put together a few slides at Indu's request, just to introduce the topic. And then hopefully we'll have some time for questions. So shall I share my screen?
Sure, that sounds great. Thank you.
And we just get going. Right, can all of you see my screen?
Yep, that's perfect.
Fantastic. Don't have any disclosures really relevant to this topic. Essentially what I will be taking you through in the next sort of 20 minutes or so is try to explain why urinary problems occur in the setting of Parkinson's and really what can be done about these, about urinary problems. So many of you are familiar with the person called James Parkinson. You might not be familiar with this monogram, but this was published in 1817, just around 7 miles from where I'm sat right now. And this was an essay on a group of individuals who he saw, who he described as having a shaking palsy, which later became known as Parkinson's disease, named after James Parkinson. As you will note, he was a member of the Royal College of Surgeons and not of physicians. Now, it was interesting, very little at that time was actually mentioned about bladder problems in this condition. And so was the case for many years. And there have been great strides in terms of understanding the underpinnings of Parkinson's disease, how it affects the brain, and also different therapeutic options have emerged over the years in terms of problems with mobility. But when it comes to sort of non-motor symptoms, there's actually been a gap. And this has been addressed in the last sort of 15 to 20 years, and there's been quite a bit of work done by a non-motor system group. There's now a group that's now functioning. And this is a questionnaire that came out of this, and it's called the NMS questionnaire, the Non-Motor Symptoms Questionnaire. And this slide is not meant to be read, but essentially it's around 30 questions about different symptoms that are not related to the physical disabilities of Parkinson's, but with regard to problems with the bladder, the bowel, mood, sex, about pain, sensory symptoms. Now, when a large number of individuals with Parkinson's actually were asked to fill out this questionnaire, and their different symptoms were then sort of tallied, it was found that actually bladder problems by far emerge as the #1 symptoms that individuals with Parkinson's reported in this sort of realm of non-motor symptoms. And amongst them were the symptoms of nocturia, which is getting up at night to pee, and urinary urgency, which is this compelling desire of needing to rush to the toilet when there's a signal from the bladder that tells you that you need to pee. So this takes me to really about the different types of symptoms. And I think when you have an opportunity to actually discuss the bladder, could be with a general practitioner, with a neurologist, or with a nurse, it's important to recognize that there are two sets of symptoms that an individual might have from the bladder. You have symptoms where the bladder can't really store properly. So there's urine in the bladder, but it has to come out. And these are symptoms of urgency. There's frequency, which is going to the toilet more often in the day or the night. And of course, when one gets caught short for the toilet, incontinence or leakage of urine. So basically a situation where the bladder is unable to store urine. Now you have problems also with voiding. So when during the act of peeing, there could be a bit of a delay in sort of starting trouble, trying to get the urine to start, what we call hesitancy. There's perhaps straining when trying to pee, an interrupted stream, and also something called double voiding, which is sort of peeing, thinking that everything is out, and perhaps even getting up from the toilet, and then within a few minutes of having to go again. Now, between these two sets of symptoms, storage symptoms are easily recognizable. Either you'll go to the doctor and tell them, well, look, I've got problems with getting up at night to pee, I've got urgency, or perhaps I have unfortunately problems with leakage. Or if the doctor asks the question, well, they become part of a conversation quite soon. However, voiding symptoms are not that straightforward unless you've gone into urinary retention where you can't pee urine. It becomes noticeable. For most individuals, actually these symptoms of hesitancy and an interrupted stream are quite gradual, and we tend to get used to it over time. Unless we frequent public toilets and sort of observe with the next person's how they're peeing, we might not actually recognize that there's actually a problem with voiding. And this is actually quite important because voiding means bladder emptying. So many of us actually, without realizing, might not be emptying our bladder to completion. And hence, the most important point I'd like to make is that if you have a battery of assessments that are needed, the most important assessment for the bladder is checking to see how much is left behind the bladder. Now, this can be easily done by a bladder scanner, and in many clinics there are handheld scanners that are available, which a nurse can actually sort of scan the bladder if the person has peed. It tells you about what's called the post-void residue, and I'll come back to that in a few minutes. Now, in Parkinson's, we know that the onset of symptoms is a bit unpredictable. We don't know when symptoms can occur, start to begin. But what we do know, however, is that once the symptoms do begin, the severity of symptoms and also the number of patients who get affected actually increases over time with regards to the disability of Parkinson's. So we know that individuals we know that as the disability becomes more and more individuals actually become symptomatic, but we also know that the severity of these bladder symptoms also become worse as well. Now, I mentioned earlier that nocturia, or getting up at night to pee, is the most frequent symptom. It's not necessarily a complaint, because I would say that beyond a certain age, probably most of us who are tuned in this evening actually do get up at night to pee, and we don't necessarily consider that as a problem. And so the perception of nocturia is slightly different from the symptom, but it's important to recognize. So this is just a bladder diary. And I don't know if you can see me using a cursor, but essentially I've shown what time a person gets out of bed in the morning at 20 to 8 in the morning, and they go to bed at 11 p.m. And so what the person has done with the measuring jug is they've recorded at what times they've peed and the volumes they've peed as well. And so you can find that they've woken up in the morning, and this is all they've peed in the day up to here. And then, of course, their night starts, and you can see that they've been interrupted 1, 2, 3, 4, 5, 6, 7 times at night. So it's not just an increased frequency, but it's also then doing the maths and calculating and measuring the volumes. And so when you calculate the volumes, you find that during this period of day, which is from 7:40 to 11 o'clock at night, this person has actually produced only 400 ml of their entire urine output. Whereas in the night, if you do the maths, you find that they produce nearly 1.6 liters of their urine output at night. Now, this is something that's not uncommon in people with Parkinson's, because essentially what they have is that they're producing a large urine output at night, which is called nocturnal polyuria. So in most people, they would be producing no more than 1/3 of their entire urine output at night. And here you can see this gentleman has produced 80% of their entire 24-hour urine output at night. Now, nocturnal polyuria is sort of like the elephant in the room, because a patient will talk about their problems with Parkinson's, and at the end, there's probably a footnote about, well, I've got nocturia, and that's it. But actually, when you start inquiring about the volume, so you start asking about the urine production, you might find that actually it is nocturnal polyuria that is driving this nighttime frequency. And this is important to recognize, because there are different causes for nocturnal polyuria. We know there's a relationship, for example, with problems with blood pressure. So if your blood pressure tends to drop when you stand up, what we call postural hypotension, we know there's a link with nocturnal polyuria. But it's more of a medical condition rather than a surgical condition, such as an enlarged prostate. So when there's nocturnal polyuria, as a physician, the physician in me kicks in, and we start asking about the heart, the liver, the kidneys. We start about medications, because they might be on a water tablet before they go to bed at night. They might be drinking too much at night. They might be having ankle swellings when they go to bed at night, and all that swelling gets absorbed at night, and then it comes out through the bladder. Or they might be having sleep apnea, which is a condition where they snore at night, and they have momentary periods when they sort of stop breathing. It's called obstructive sleep apnea, and we know there's a link between that and nocturnal polyuria. So it opens up so many different possibilities, and many of those conditions that I've just outlined are actually treatable. Now, when it comes to bladder problems in Parkinson's, we do need to think outside the box, because there are different causes for bladder problems. And we must think about, of course, Parkinson's and how it affects the bladder. Now, there is a link between dopamine levels and bladder control. We know that, that dopamine is important for inhibiting the bladder. So I think imagine that in health, when you go out to the shops or out to the beach or wherever you like, especially when lockdown is over, you really don't want to be bothered by your bladder. Essentially, parts of your brain that we call the frontal lobe, they inhibit, they suppress the bladder, and so you can go around for a reasonable period of time without being bothered by the bladder. So essentially, it's inhibition from the brain to the bladder that suppresses the bladder and keeps your bladder in check. Dopamine and other neurotransmitters actually are the ones that affect this inhibition. So when there's a deficiency of dopamine, this inhibition of the bladder is lifted, and the person develops an uninhibited bladder, and they start going more often to the toilet. And this is supposed to be one of the mechanisms by which individuals with Parkinson's develop problems with an overactive bladder. Now, an individual with Parkinson's may have so many other medical conditions that can contribute to their bladder problems as well. It could be a middle-aged man or an elderly man with an enlarged prostate. It could be the ankle swellings or pedal edema that's sort of contributing to the bladder symptoms. They might be having other medical conditions which can predispose to bladder problems, such as diabetes and heart failure. They might be on medications that make them pee more frequently, for example, water tablets or diuretics. They might be having different sleep disturbances. So I mentioned sleep apnea, but we also know that individuals with Parkinson's have disturbed sleep for many reasons. Many people with Parkinson's, they wake up because of that disturbance. It could be because they had a bad dream. They might have enacted their dream. But what happens is they're up and they think, well, I'm awake. I might as well go to the toilet, though they're not particularly needing to go to the toilet. We call this as a convenience void, because essentially it's convenient. I'm awake for my sleep. I might as well go to the toilet. Now, as a physician, it's quite important to recognize these, because I don't really want to be treating that with a bladder tablet. I want to be understanding why there's a sleep disturbance and why this person woke up at night, and then they go to the toilet. And then, so it becomes a much more holistic management. We talk about sleep apnea in particular, which I think is quite, though there isn't a greater prevalence in Parkinson's, I think in general, with increasing age, there's an increasing prevalence of obstructive sleep apnea syndrome, once again, treatable. And of course, this person with Parkinson's may have other neurological comorbidities, such as they might have vascular disease affecting their brain. They might be having cervical spondylosis, a slipped disc in their neck, which is pressing on the cord. So as a physician, I think when an individual with Parkinson's comes to me, I think about the other medical conditions that can be contributing to their bladder problems. And this can actually be quite tricky, and which sometimes means that an individual with Parkinson's may need to be investigated with tests, which I'll take you through shortly. Now, if an individual with Parkinson's was fairly stable with their bladder, and if they come to us saying that, well, you know, in the last few weeks, there's been a change. My bladder's playing up before it wasn't. Now, we know that can't be neurological, because we know that in Parkinson's, it's not very common for things to occur acutely. You do get a bit of a lead time. However, when a person starts telling me about problems of recent onset incontinence, I need to start thinking about other conditions. I think number one on that list is urinary tract infections. So unlike a young person without any neurological disease who can perceive their bladder sensations, who know about their bladder and what to do, who have no problems with mobility, when they get a urinary infection, they really feel it. They have symptoms of cystitis, or burning in their bladder, or burning sensations when they pee. They can smell their urine. It's foul odor. They can see that it's different. It's more cloudy. In Parkinson's individuals, often it's more subtle. So a person with Parkinson's may not perceive that smell of a nasty smelling urine, so may not realize that. They might not recognize the urine is turbid. And the symptoms can be more subtle. Sometimes it could be just increase incontinence. Sometimes it could be just a worsening of their Parkinson's symptoms, more falls, worsening disability. And actually, as a neurologist, I start thinking, well, is it due to the Parkinson's? You start investigating different causes, and actually you find that actually it's a urinary tract infection, which is rather subtle, which is actually the cause for recent onset incontinence. Sometimes it could be a change in incontinence. So some individuals with Parkinson's need pills that help with boosting their memory. Now these tablets, such as rivastigmine, for example, are known to worsen urinary frequency and incontinence. So I go in to find out if there's been a change in their prescriptions. Opiates sometimes need to be given at the last resort for individuals with Parkinson's with pain. Now that can really mess up the bladder and bowel functions. Now sometimes there could have been a recent restriction of mobility, for example, a fall or a hip surgery. So the person who had a bit of urge but could have made it to the toilet previously, now because of their change in mobility, the change in circumstances, are no longer that mobile, and then they become incontinent. Now, something that's missed, and I think I must admit, even time and again, I've missed in my practice, is constipation, because we know there's a link between the bowels and Parkinson's. We know that constipation can actually mess up bladder functions. Now, you might think that this could be, a mechanical effect. You have a loaded rectum. This could be sort of blocking. It could be sort of obstructing the bladder. This is plausible in men. Do you remember in women, there's a womb in between, so it's not that simple. I think it's more of an electrical reflex, and we know that when the bowel, the rectum particularly, is distended or enlarged, we know that that can interfere with bladder functions. And so, and time and again, I've come across individuals where we've just managed their constipation and their incontinence has actually resolved. Also, it could be the other way, urinary retention, which they have had in the scan, actually resolves as well. So if you were to then come to a healthcare professional and open up the conversation about the bladder, I think what we would do as a healthcare professional is ask a few more questions, some of which I've shared with you earlier. We would certainly test for an infection. Once again, we don't want to miss something that's entirely treatable and curable if we pick up the infection. We will check your bladder that's empty. Now, in facilities where there is a handheld ultrasound, it can be done then and there in the clinic. If it's not available, you might have to go to a radiology department with an ultrasound, and it can be done. In some centers where it's just not feasible just to get an ultrasound, just because of distances and what have you, it's performing an in-out catheterization. So the nurse would just put in a catheter, take it out, empty the bladder, and then check what's left behind after the person's voided. We would almost invariably ask you to keep a diary, similar to the one I shared earlier, and you need to get yourself 2 measuring jugs, one to measure what volumes you pee and mark at what times, and the other measuring jug to measure what volumes you drink and at what times, and importantly, what you drink as well, which I'll come back to in a few minutes. We might ask for some tests like urodynamics, which I'll be happy to answer questions about that during the questions, and also we take you through different treatments. Now, this is an example of a bladder scan. This is just in our department. Our nurses have just measured the post-void residue after the person has peed, and there's a significant amount of urine in the bladder. Now, remember that stagnant water is a breeding ground for bugs. So just having a high post-void residue itself can predispose to urinary infections, and this is why I think it's quite important that we recognize this. Also, remember that when there's that much of urine that's sitting inside the bladder, your bladder really has little volume left to fill. So this itself can drive urinary frequency and urgency, and so it itself can cause your storage symptoms. And we've find time and again that just by emptying the bladder and just by sort of initiating treatment for bladder emptying, that actually individuals post-void residues actually, their storage symptoms, their urgency and frequency actually improve. Now, these are sort of the algorithms we follow. I won't take you to the depth, but just sort of show that, the first line treatment are, we go through, we start with practical management. We talk about sort of 1.5 to 2 liters of fluid a day, which is around 6 to 8 glasses. We have a conversation about alcohol caffeinated beverages like tea and coffee, any citrus products, orange juice, grapefruit, any fizzy drinks, sparkling water, your sort of colas, which we know can irritate the bladder. And we try to eliminate all those sort of irritants for the bladder. We talk about sort of training the bladder so that we try to get the individual to delay in a gradual process the visit to the toilet when they experience an urge. And also we talk about sort of timing the visits to the toilet, bladder scheduling. These particularly help in the early stages when the bladder symptoms are relatively mild. We talk about sort of different sort of appliances and also aids at the toilet with regard to help with accessibility. Sometimes when there is problems with freezing, problems with mobility to the toilet, we talk about like having a portable commode. So this is actually quite discreet. Once the seat cover is on, you might not even recognize it's a commode. Sometimes a jug is useful. And also we talk about sort of the apparel and what they're wearing, sort of Velcro, for example, so it helps with sort of unbuckling and unbuttoning oneself when you experience the urgency. Because time and again, it's a problem that the person has, catches sight of the front door, catches sight of the toilet door, or catches sight of the toilet, begins to undress themselves, and that's when they become incontinent. And things like these can sometimes help. Now, there are different pills that are available for the which are called antimuscarinic agents that are available for managing the bladder. And there is some evidence to show that these are safe and effective for managing bladder problems in Parkinson's, but these are clearly not for everyone. And so it is quite important that there's a conversation between, with someone who's knowledgeable of Parkinson's, but also knowledgeable about these pills, so that we make sure that you're on the right tablet. There is another group of tablets called, it's called Mirabegron, which is available in the United States as well. And it works entirely different from the other group of drugs that we call the antimuscarinic agents. So essentially, you have two groups of drugs, and perhaps during the questions, I can sort of take you through which one would be preferable and what are the sort of the side effects that you want to be looking out for. Something else that's come up is something called tibial nerve stimulation. Now, this is the nerve that sits here behind the ankle. You can see this picture on the lower right quadrant of your slide. So this nerve is electrically stimulated. It's been shown that by electrical stimulation of that nerve is actually an effective treatment for management of problems of urgency, frequency, and incontinence. There is some evidence to show that electrical stimulation of the nerve is effective in people with Parkinson's. And we've just, in the UK, concluded a randomized controlled trial evaluating tibial nerve stimulation of Parkinson's, and we're just in the process of analyzing the results. Essentially, you can deliver this either by a needle. This is an acupuncture needle. This is called percutaneous tibial nerve stimulation, or PTNS. Or it could be using a TENS machine, as you can see here. So the patches can be stuck onto the leg, and the electrical stimulation is delivered, usually by convention half an hour, and it gets over 12 sessions. Now, the advantage of the transcutaneous approach, which is the one with the TENS machine, is it can be done from home. So we can set up the patient through Skype or through Zoom, and the patient can actually carry out the treatment at home. There are other treatment options, such as botulinum toxin injections into the bladder, which I'll be happy to field questions for in case you have any questions. Now, I do want to, however, mention something about if the post-void residue is high, and it is sort of in that stage having a conversation about catheterization. We always prefer self-catheterization because that retains the independence of the individual. There are a variety of catheters in the market. And it therefore takes a conversation with someone who's knowledgeable about catheters and who's also knowledgeable about Parkinson's, or at least neurological disease, so that we make sure that the individual is set up on the right type of catheter. Now, in some individuals, it would be appropriate to have an indwelling catheter, which means it's not intermittently done, whereas it's actually left inside. And there are two routes. One is down below through the bladder. So this is through your natural opening that we call the urethra, through which you pee through. And the other is through an opening made in the belly, the lower belly. It's called a suprapubic catheter, SPC. And that's what this figure actually depicts. And so in some individuals in whom we find that incontinence is really difficult to manage, where there is some retention and the person's unable to perform the intermittent catheterization, or we just find there's increasing disability of the bladder, just pulling the individual down. Sometimes an indwelling catheter is the way forward. And we prefer a suprapubic one than the urethral, just because of issues of hygiene and trauma that can occur when the catheter is left down below. And that's how we would leave it. And there are sort of a conversation about different types of bags and valves. Now, some people just require some device for containment. So you have sort of convenes or penile sheets that are available. And there are different sort of absorbable products, such as pull-up pants, pads, for example. It's a huge market, which I think for the individual Parkinson's is a bonus, because there's quite a bit that's available. And so if one doesn't work, there's another option. What we need is an empathetic continence nurse who will take you through the process. So just to recap, I just want to sort of highlight that urinary problems are quite common in people who have different types of movement disorders, such as Parkinson's. The key bit when having your bladder assessed is to check that your bladder is actually emptying or not, and also to check for a urinary infection. Depending on your individual case, you might need further investigation, such as urodynamics. I would say the cornerstones of conservative management include looking at your fluid intake, pelvic floor exercises. There are different pills available for the bladder, and also electrical stimulation of the nerve, of the tibial nerve. Now, if that doesn't work, there are options such as botulinum toxin, and in some individuals, an indwelling catheter may be required.
Wow, that was amazing. You know a lot about the bladder, and this has been a lot of information, I think, to digest, but just fabulous. And people can hopefully go back and watch the YouTube video, and I think there's been some requests even to take a look at your slides and things. So I think you've really summarized a huge amount of information and really just amazing work that you're doing there, because I think, you know, this is a real really unmet need in our field, and I think you have such a wealth of knowledge. So thank you so much for covering all of that. So I think we can take a few questions from the audience, and then maybe we'll generate some other questions as we're going through here.
Sure.
One question that came up is it better to train your bladder to hold or to let it release as frequently as needed? So I think you touched on that about the bladder training. Maybe you can spend a little bit more time telling us kind of about some strategies and why it would be important to try to train your bladder.
Great. I'm just going to switch the lights on because it is becoming dusk here. Right, so you can see me better. Sorry about that. You must remember that there is a situation of an overactive bladder here. And so there's a bladder that's trying to push the urine out because it's essentially uninhibited. And so in the early stages, particularly, what happens is, imagine that you have a bit of urge and for the very first time become incontinent. Or it's a special occasion, a night out, or perhaps the cinema, and you have this urgency and it disturbs the ambience of the evening. You become quite anxious about your bladder. And what you do is then you go into a habit. And so you then go to the toilet just in case. So you really don't need to be going. The overactive bladder isn't that bad. However, it's in anticipation of being caught out at a potentially embarrassing situation. And so in that sort of situation, and it is very much mind over bladder, as you can see. And so that situation, bladder retraining is particularly helpful because actually it gets you to train your bladder so that you get more control of the bladder. So rather than the bladder ruling what you do, it's the other way around. But it has to be done in a gentle process because there is an overactive bladder. We might not expect to be able to hold the bladder for 4 hours or 5 hours, but it's sort of gradually increasing that period to find what is safe and what is comfortable for that individual. And I think having a continence nurse or a physio involved in the process just to sort of take you through the process is immensely helpful.
And are there many of those sorts of people where you work? Because I don't think we have, I think one of the questions is who should be addressing some of these things? And I think there's been, because there's such a lack of people who have, I think, the knowledge base that you have, it hasn't been a great, a lot of the Parkinson's doctors may not be asking these questions and may not be comfortable knowing. I think we know some of the basics, about, treating constipation, looking for urinary tract infections. I think those are, the pretty basic things. And a lot of the times we end up referring to a urologist who may not have that much knowledge about Parkinson's disease. And there's this sort of gap between the two. So I think, hopefully there are people that you may have colleagues in the United States that may have some information, or if you have other resources, we would love to share them, after this lecture, and definitely possibly get a copy of your slides so that people know even what questions to be asking if they go in to see a urologist, to sort of help point them in the direction of where they should be getting help.
Absolutely.
I think that's helpful. So there was a question on constipation creating pressure on the bladder and cause for frequency. And I think you did answer that, but are there ways to diagnose that? I mean, I think you can have a sense of if you're, how many bowel movements you're having, but when you're scanning the bladder, are you able to see other structures? I mean, how do you guys approach that when you're taking a look at some of these things from a rehab perspective?
Well, I think from I think it's just back to the history. It becomes quite apparent that there's been a change in bowel movements, but it once again might not be recognizable. So the bladder scan is actually an excellent opportunity because when we scan the bladder, you might find a shadow superimposed over the bladder, and it becomes evident that there's a loaded colon or a loaded bowel loop there, and also just sort of feeding the tummy, you can feel the distended bowel loops. And so often just by a examination, it becomes apparent. If we were to introduce a finger into the back passage, as we might do, for example, to sort of assess the size of the prostate, at that time, once again, you would feel a loaded rectum. So there are ample opportunities during the examination to actually assess that, because constipation is quite common in Parkinson's, and not all individuals with constipation is actually the constipation related to their bladder dysfunction. But I think bringing up the bladder problems and having that assessment goes a long way in assessing that side of things. Okay.
And I think hopefully we'll have a constipation or GI expert on in the next series of talks. And I know you work with one closely that we'll try to get on as well. There's a question about the penis has become so small, difficult to hold. There's a problem aiming into the toilet. Do you have any thoughts on that?
So it is something that we come across, particularly in Parkinson's. I think it's essentially a retraction of the penis that happens. And I suppose what happens is that over time, if we use the penis less, if it becomes less erect, the erectile tissue sort of regresses in size, and the penis tends to sort of get buried into the scrotum. On top of that, often individuals might have a prominent foreskin. And so the penis, that doesn't help. The entire penis gets buried in the foreskin and then into the scrotum. There's not much medically that can be done in this situation. But we have found that by a circumcision, by sort of operating and cutting the foreskin, it exposes the head of the penis, and essentially there's a bit of penis. It's more easy to hold and access, you see, whereas with the foreskin that's sort of flabby over the penis, it just gets in the way. My colleagues in France will say that take a Viagra a day can help just to keep the erectile tissue, but just to get it sort of congested, but there's not much of evidence for that. And I must say that it's something we certainly don't advise. However, quite a few individuals with Parkinson's who take pills for erectile dysfunction, for example, once a day, tadalafil, for example, that's a once a day pill that you would take. I think that would, it would be something that's, it might help with the retraction side of things as well. But of course, the primary indication would be for erectile dysfunction. Now, if it is that the case that retracting sort of the cutting the foreskin is not the way forward, it's not helpful, in that situation, I think it's really a discussion about an indwelling catheter.
Yeah, I mean, I think those sorts of patients, sometimes we'll try a condom catheter, so a catheter that looks like a condom and they wear it at night with a bag. it becomes very hard to put the condom on when the penis is so small or not able to keep it on. Basically, it slips off. So,
well, it
so I
slips
think,
off, and yeah, and it slips off, and I feel that's I mean, it's a loss of self-esteem, confidence that happens when it slips off, and it's a tricky one. But once again, having a continence nurse work on that, I think, is something worth engaging with a continence specialist team.
yeah. So perhaps working with a urologist and their staff, nurse practitioners, nurses. And then I think, even your background of being a rehab doctor, maybe an additional person in the United States, some of the rehab doctors, physical medicine and rehab, may have a background in managing constipation, managing urologic disorders, sometimes from spinal cord injury. That might be an additional group of folks that may be able to help if patients are feeling like they're missing, the neurologist and the urologist don't seem to really have helpful tips. Maybe seeing a rehab doctor may be an idea as well. There's a question about uterine prolapse affecting urinary function. We hear a lot about men's urinary problems, but not enough about women's.
Mm-hmm. So it's quite common, I suppose, particularly in this age group. I think it's something that we ask about, we look for. Because if there is a prolapse, well, it's something that's it's treatable, it's curable with a pessary, with surgery. I would say that most often women with prolapse will know they have a prolapse because they will feel a heaviness down below. In fact, I think it's a rather reliable bit of history that if they feel that there's something coming down, they feel there's a heaviness. I would say it's a rather sensitive bit of history that they volunteer. And a pessary is something that's introduced. It's which actually keeps the prolapse up. It sort of reduces the prolapse. And if there is a noticeable improvement in bladder symptoms, then we know that's contributing to the problem. Some women do well with the pessary for years. For other women, that's not the case, and they end up going on proceeding with a surgery, such as a hysterectomy or the appropriate surgery. But clearly, we don't see it in terms of just Parkinson's in the bladder, be it men and women. We think about sort of the urological causes that could be contributing to it. I think it's the other way around that the problem is, because I think when you have a non-neurourologist seeing the patient, there may be a bit of an enlarged prostate or a bit of a prolapse, then everyone thinks it's all due to that. And I think this is where we get it wrong, because we then assume that everything is due to that small prolapse, so that slightly enlarged prostate. And these are sort of the cases where I think it's quite important to investigate. And a test called urodynamics is particularly an important test to have, because there we can actually demonstrate that this enlarged prostate or that this prolapsed womb is actually pressing upon the urethra, the bladder. And if we demonstrate that, then actually it strengthens our, it helps us sort of in managing the case.
Okay, that's a good answer. There's been a few questions on Myrbetriq, and I know I've been in a couple of lectures that you've talked about that drug as a pretty novel medication to use in this population. Some of the other medications that you did post about that affect the cholinergic systems, the anticholinergics, I will just say the caveat that some of these medications can cause cognitive changes and sometimes even induce hallucinations in some of our patients. And so it's definitely, these are medications that if your urologist puts you on, you want to make sure that the neurologist knows. And if there's new symptoms that are in the mental state or like seeing things that aren't there, that everyone's communicating, because that can be a side effect of some of these medicines. But maybe you can just speak to Myrbetriq, which I think is a unique option these days.
So till a few years ago, we only had those other drugs called antimuscarinics, and as you point out, they do have side effects. I think in particular, it's about constipation. They can make constipation worse. They can give you a dry mouth or dry eyes, which many individuals with Parkinson's already report. But then, and also the cognitive issues that are there. Now, mirabegron is an entirely new class of drugs, and it works in a different protein in the bladder. And so it's devoid of many of these side effects. It works at this protein, and it helps with relieving urgency frequency. I must say that it's not licensed specifically for the neurological overactive bladder. It is, however, it is licensed for the overactive bladder in general. We do use it quite often in individuals with Parkinson's with beneficial effects. I must caution you about the side effects that include palpitations and a rise in blood pressure. So if there's issues with blood pressure, then that needs to be closely monitored whilst on mirabegron. And also if the blood pressure is more than 180, 110, then it shouldn't be used. But it is something that we use, and sometimes we use it in combination with the antimuscarinic pills.
Interesting. Okay. Somebody's asking about fizzy drinks. So what is the issue with the fizzy drinks? Is it the actual carbonization or the ingredients in the soda? I ask because I carbonate my own well water and don't add anything else. So it looks like, and I'm drinking some fizzy water right now, which I love, but is it the carbonation or is it the caffeine that's often in them, or what is it about the fizziness?
To tell you the truth, I don't think we know. It's just an observation that's from I would say from time immemorial that having fizzy drinks makes you pee more often. I suspect it must be the caffeine that's added to the fizzy drink, or whatever aspartame or whatever is added to the fizzy drink. But even individuals who just have sparkling drink alone, they do find that they pee more often. They have more urgency and frequency. Now, I won't say that cutting out the fizzy drink will cure your overactive bladder, but certainly takes the edge off of the overactive bladder symptoms. And so someone who has 6 or 7 of those glasses of fizzy drink every day, if we ask them to cut back on that and sort of balance it with sort of still drink, we often find that their bladder symptoms tend to improve. I suspect that the carbonation process also is resulting in some degree of irritation. With caffeine specifically, remember it has a diuretic effect as well. That's not specifically for fizzy drinks. So.
Yeah, and I think diuretic effects are in many things that we don't even recognize. A lot of the juices and a lot of the caffeinated, there's mildly caffeinated tea, green, there's teas that have caffeine in them. And so when we look at people and what they're drinking, I think it's helpful to find out and report to your doctor exactly what you're drinking. Can be helpful. There's a question about Desmopressin nasal spray. Mm-hmm. And what you think about that?
So desmopressin is actually a hormone that's produced by the body. What it does is it promotes reabsorption of your fluid from the kidneys. So essentially, when your brain secretes desmopressin, there's actually less urine that's being produced. So this is something that's natural, that occurs in all of us. Now, desmopressin is also available as a synthetic form that you administer either under the tongue or through the nose, intranasally. So basically what you're doing is you're supplementing the desmopressin that's being produced by the body. That's particularly useful in individuals who need a short duration of bladder control. So this is typically nocturia, when you need sort of 4 to 6 hours of relatively nocturia-free sleep, and desmopressin is particularly effective. During that period of time, what happens is that your fluid from the kidneys are getting reabsorbed, so you have less urine that's being produced by the kidneys, so less urine reaching the bladder, and hence there's less need to go and empty the bladder. And that's basically the principle of desmopressin. Now, because the fluid is reabsorbed, I mean, that has to go somewhere, and it basically enter your circulation. So if you're already congested, that means you're adding more fluid to your system. So if you've got ankle swellings in your legs, it means that you're already congested. If you have heart failure, or liver failure, or kidney failure, it means that you're already fluid overloaded. Now, on top of that, if this fluid is getting reabsorbed, there's a situation when your congestion becomes worse. And so it has to be used with caution, and that's why you need medical advice before starting desmopressin. Now, when the system becomes overloaded with fluid, what happens is your blood becomes dilute. And when your blood becomes dilute, your salt levels begin to drop. So some people who take desmopressin, they have a condition called hyponatremia, which means that their salt levels drop. And so individuals who take desmopressin should actually have a sodium level or the salt levels measured periodically. Recently, it occurs more likely in people who are elderly, so above the age of 65, or people who have ankle swelling. So in individuals more than the age of 65, we would use this with caution. I think the question pertains to a recently licensed product for Nocturia in the elderly, which is a low dose of Desmopressin, which is a dosage of like 50 micrograms. So it's much smaller than the usual dosage. And that has actually been shown to be effective in the elderly with Nocturia. In Parkinson's, once again, not licensed, but we do use it cautiously to help with their Nocturia.
Okay. There's a couple questions and like a comment about biofeedback for training your bladder. Somebody else says, why does the urge to void increase so fast, so quickly? As soon as I think I have to go. Could mind over matter type visualizations or exercises make a difference? And Jalesh, you and I have talked about some possible strategies from the mindfulness yoga intervention universe. So maybe you could just speak a little bit about your thoughts.
Yeah, yes. I mean, I think you have to think about this in terms of interoception. So, I mean, essentially, you're perceiving sensations from your bladder. And in health, what happens is you perceive that sensation in parts of your brain, and called the insula, and that tells you that your bladder is getting full. Now, with normal faculties, what happens is that you can then sort of decide whether you need to then act on that signal or not, and then you go to the toilet. What happens with Parkinson's is that there's an overactive bladder, so the bladder is sort of firing away, it's playing up when it shouldn't. But also, because of changes that are happening in the brain part of Parkinson's, is that our perception of sensations are different. And also, what we do in response to the sensation, in response to the threat from the bladder, is actually altered. So mindfulness, and on top of that, remember that in Parkinson's, there's an increased prevalence of anxiety and other sort of symptoms. And so mindfulness and other symptoms actually go a long way in actually relaxing the bladder. There isn't any evidence, I'm afraid to say, but however, from our practice, what we find time and again is that it is through bladder retraining. Part of it is sort of is learning how to control our response when we perceive a threat from the bladder, i.e., we might become incontinent. And so therefore calming the bladder down. Now, the graded sensations of the bladder getting partially full and then fuller and fuller and fuller and then full, that unfortunately doesn't happen. And so sometimes it's all or none, that you might be fine sitting, listening to this talk, and then suddenly you find that you've got urgency, you've got to get up and go. And that's all part of this altered perception of the bladder. And so this is where bladder retraining helps, but also timing of the bladder so that we sort of make sure the bladder gets emptied periodically at regular intervals.
So what you're saying is that maybe every 2 hours you try to go to void, but then when you're getting that urgency to pee, especially if you're not terribly affected by the bladder, perhaps just waiting, maybe trying some breathing exercises or counting maybe or something, or closing your eyes and or focusing on something else for 5 minutes or 10 minutes may be helpful. Is that sort of the thought?
I would say particularly in the early stages when the bladder is just beginning to kick in, and where it might not necessarily be an impact on quality of life, but it's still a bother. Particularly at that stage, I think when you at that perception of urgency, actually adopting these sort of measures, I think can help. And also think about another thing, the pelvic floor. I mean, remember, when we all need to pee, what's the first thing we do is that we squeeze our pelvic floors without knowing it, or we cross our legs. Basically, what we're doing is we're tightening up down below. And so at that particular time, I think then remembering to squeeze your pelvic floor, actually that can suppress the bladder. And time and again, you might find that you can tide over a potentially embarrassing situation by squeezing your pelvic floor. So pelvic floor exercises, relaxation techniques, closing your eyes, trying to sort of a distractor can go a long way, particularly in the early stage when the overactive bladder side of things, because of the Parkinson's, hasn't really gone in that much.
Okay. There's a question or two on supplements, sort of. There was one on a medication or a supplement called beta prostate. I don't know if you're aware of that. I just looked it up. It has zinc and selenium in it. Are there any supplements that you recommend for bladder issues or even for prevention of urinary tract infections in your patients?
Well, there's two questions there. So I would answer the first bit and say I'm afraid that there are no supplements in terms of bladder symptoms. We do come across individuals with Parkinson's who come with all sorts of tablets to our clinic supplements. I mean, I suppose if cost is no barrier, then there's no harm, but it is an issue. When it comes to urinary tract infections, I think cranberry tablets, something called D-mannose, these can help with preventing infections, particularly if they're due to a bug called E. coli, which I'm not sure if you're familiar with. But it's a common cause, the commonest cause for urinary tract infections. And there is evidence to show that these supplements can help with preventing UTI. But once again, it's a discussion with your medical practitioner about what is the cause for the UTI. And importantly is that these may be helpful in preventing infections, not treating them.
Yeah, absolutely. I think that both cranberry and D-mannose have been shown to prevent E. coli from adhering to the bladder wall. So I think those are some reasonable options. But I think if you have a known urine infection, I would not treat with cranberry, or I would actually get antibiotics. And, and I think hydration helps with flushing the bladder as well with, just keeping, you don't want to get dehydrated if you're prone to urinary tract infections. So I think those are very reasonable. And what about saw palmetto? Is your sense, does that just work for big prostates, or what's your sense of that?
I would say it's probably more for enlarged prostate. I couldn't be seen as recommending it. I don't have any personal experience in terms of patients that have come back and reported benefits with it. It's something that's marketed. There is some very limited evidence, though I must say the quality of the evidence is rather low.
Okay. We just talked about the cranberries. Does vitamin C supplementation or acidification of the urine help? There's a question about that.
People try it. I'm afraid there's not much of evidence to support it. Doesn't do any harm, I suppose, but really nothing to benefit, I would have thought.
Okay. I mean, we have 4 minutes left, so maybe we'll take one more question. I mean, there's so many questions coming through. Everyone's really fascinated by this topic, and I have to say the numbers of folks that are joining us today are quite extraordinary. So we're so excited that people are interested and that you're getting so many people educated on this important topic. So maybe the last question that I'll ask you is about your tibial nerve stimulation, because there's been a few questions about that. Can we use it in the setting of deep brain surgery? If you have stimulators here, are you able to stimulate elsewhere? And then also, what is the mechanism? Why do we think that this works is the question.
So I suppose I'll answer that second question first. We don't know. We think it's a modulation of a neuroreflex at the level of the spinal cord. So essentially, when you stimulate the nerve at around 10 to 20 hertz, it sort of interferes with the bladder signaling occurring in the spinal cord. And that sort of level at that level, that modulation, what it does is sort of suppresses the overactive bladder. It's why I say we don't know is that for urinary retention, not in Parkinson's, but in other conditions, it's supposed to be effective as well. Sacral neuromodulation, particularly. So it's a modulation of a functional disturbance in bladder control. Now, it is the sort of individuals who shouldn't be having this treatment is if you have an implanted defibrillator, or if you have a pacemaker of the heart. But if you have any other stimulating device, if you go by what the company says, actually there isn't a contraindication. So deep brain stimulation is something that we discuss with our movement disorder guys often. And at the end, I think it's pretty clear that it is safe to use tibial nerve stimulation in people with the deep brain stimulator.
Okay, that's very helpful. And then I think we're pretty much almost done here. I was wondering if you have any other, I think there's been a lot of interest in this pelvic floor squeezing and bladder training. So if there's resources that you can point people to so that they can look that up, I think that would be really helpful. One person asked about they're using the pelvic floor thing, it can hold, but as soon as they stand up, they have leakage. I think it's a woman. So are there any suggestions for that? Maybe that can be our last question, and then we'll wrap up here.
Well, I suppose is how the pelvic floor muscles are actually being contracted. I think most women have, unlike men, know their pelvic floor muscles. whereas men just don't know about the pelvic floor muscles for obvious reasons. But I think the way we do it after childbirth is actually different later on in life. And so we tend to assume that we know about Kegels exercises and pelvic floor muscles exercises, but often it's worth going back to a certified sort of pelvic floor physio or a physiotherapist to make sure that you're doing it right. And I think doing the technique right goes a long way in making it work, really.
That's awesome. Okay. So this topic will have an immediate impact on my outlook and behavior to effectively manage my bladder symptoms. Thank you. This was excellent. You have you have some fans out here, Jalesh. We might have to import you for a real in-person seminar or a day or a week of seminars, because I think this is such a huge topic and so unmet need. So I'm so glad that you could make the time, and we may have you back. So, but thank you again for joining us at the nighttime in the UK. And we wish everyone here safe and, you know, be well. I know a lot of us are, I mean, I have, it's very scary here in the United States in many cities right now. And we just, you know, need to all protect ourselves, stay indoors, take care of yourselves, folks. We really care about you and your health and wellness. So thank you for joining us. And I think there was it's physically distanced, socially connected or something. How do we want to say it? I can't remember. Wait, let's see.
I think it's physical distancing.
But physical distancing, yeah, even though they're saying social distancing, it's physical distancing and socially connecting and virtually connecting.
Absolutely.
With our hope. So we're doing this glable connection too, which we can add to the mix.
Yes.
So thank you so much, Jalesh. I think you can see all the comments here at the end. Wonderful presentation, very, very informative. So I will send it back to you, Andrea, for the final wave, and we will have more amazing speakers. We have just like crazy amazing speakers coming up in the next month, so please continue to join us.
Great, all the best. Thank you very much, Indu.
Thank you so much. We always do a wave and a thank you, and this one goes straight to both of you. Thank you. Bye, everyone.
Thank you very much. Thank you.
Thank you. Bye-bye.
Bye. Bye-bye. Bye.